Well, good afternoon. I'm Delaware State Representative Paul Baumbach, serving the 23rd House District, which is the Newark on the west and north side of town. And I'm here for my periodic update on Delaware State retiree health benefits. I serve as a co-vice chair of that subcommittee. My other co-vice chair is Senator Brian Townsend, and the chair of our subcommittee is Lieutenant Governor Bethany Hall Long. We had a meeting on Thursday down in Dover, and I want to go over what we went over there and what is coming. It's on the horizon. So let's go in this way. So this is the agenda for past Thursday's meeting. So we went through the minutes. We looked at, and we're going to look at each of these in sequence. Looked at the goals for any changes for future retirees, both of Medicare and of pre-Medicare age. Explore that a little deeper. Talk about the motion. Again, we're going to go through all this, but just each of these pieces. Then we had a really good discussion and getting in more depth than we had done before as far as changes that we would consider and what it would take for us to consider some of the bigger changes. And we talked about the upcoming report. And so that's the meeting from the high level. What this presentation showed us is what the costs are for, this is pre-Medicare age, pre-65, and generally, and this is, it says retiree only, but these costs are those for everyone covered by the, whatever GHIP is, it's a general health insurance plan, something like that. So it's current employees and retirees who are less than 65 years of age, who are not covered by Medicare. The premium, and I'm going to put square quotes around premium, is the cost that is estimated on a per enrollee level, regardless of age and health condition. Just the average person, it costs the state, depending on which plan is chosen, $11,000 or $10,000 a year. And they're presenting only the two most commonly chosen plans, the comprehensive PPO and the HMO. The retirees pay, depending on which plan they choose, either 13% or 6.5%. And you can see what the share is in dollars. And then we've got the 15th, 50th, and 85th percentile. So relatively healthy, average health, and then average, relatively non-trivial health costs. So you can see what the out-of-pocket for the retiree somewhere, and you can see the comprehensive is better. Well, it's what a lot of people choose, yet it's often pretty expensive. It's expensive, almost 3 times the cost for the premium. And the cost out of pocket, even for this 85th percentile, is still higher for it. And nevertheless, it's the plan chosen by most people. And then what the amount is if they also cover their spouse. So you can see what the annual cost per retiree and for the retiree and the spouse in there. But that gave us some figures that we could use for a subsequent presentation. I'll show you in a minute. So then if we come here, we talked about this a little bit. So we started working on this report in maybe early September, and we started working on the draft at the previous meeting, and we got some stuff done. I'm not going to go into details here because we didn't go any further on it. And the reason was, and I'll say I've been one of the champions of this, is I don't want to work on the final report until we've done our work and we're close to doing much of our work. And I'd rather spend time this month and next month finishing our decisions, and then for the December meeting, finalizing the report of the decisions we've made this calendar year. So we didn't go any further, but we got a plan, and I'll talk about that in a little bit. So then this is my presentation, so I want to spend a little time on it. Started by, and let me get this a little smaller there. So this looks at, can I get that out of there? Can I hide it? No, stop sharing. I think I just want to hide that. There we go. You can still see it. Okay, good. So this looks at, for age 65 plus, the premium, including prescription costs, is around $5,500. This is the premium for the health program that the state contracts for. Those retirees who participate in it pay about 5%, about $276. They also pay around $400 a year on average for prescription costs. And then they're also paying close to $2,000 a year for Medicare Part B. They can pay more, they can pay much more depending on their income level, but the base level is about $2,000 a year. And therefore, the 50th percentile, the average Medicare age retiree, pays somewhere around 2,600, and the state pays about twice that at 5,200. On the healthier side, you pay a little bit less, about 2,400 a year. If you're on the more expensive healthcare costs that you incur, close to $2,800. So then what the next table shows you is, again, this is Medicare age retirees. If you've got 20 plus years of service, and as long as you're a relatively recent retiree, you're paying 5% of that premium, plus your Medicare annually, plus the out-of-pocket for medical and prescription drugs, and you're paying that $2,400, $2,700. The state pays the same for all. It doesn't matter if they're paying 95% of the premium. That's all they pay. That's exactly what they pay, about $5,200 a year. If you retire with less than 20 years service, then you're paying more than 5%, maybe 25, maybe 50, maybe 100%, and the state therefore is paying less. So my question for the subcommittee was, how much are we willing to shift cost from the state to the retiree in order to lower the state's costs and to help the state increase its level of funding of this obligation to our future retirees? Didn't get a straight answer on that, and that's fine. We had a very, very good discussion around it. But that's what this part of the presentation was. The next piece was, let's look at the sub 65. Now that we had some numbers on what the premium was, we're just looking at comprehensive PPO since it's used by the majority of state retirees who are pre-65. And they're charged 13.25%, about $1,500 a year for the premium. They also have about $840 a year of out-of-pocket costs at the 50th percentile. And because they're sub 65, they're not paying into Medicare. But that's $2,300 a year they pay, and the state's paying that, was that 86.75%, or about $9,800 a year in costs for the premium. And then if you're healthier, you're paying less out of pocket for the items that, the deductibles and copays and things like that. And if you've got higher medical costs, then you've got higher medical costs. And if you put this all together, those with 20 plus years experience or service, then they're getting that. The state's paying roughly 87%, and they're paying roughly 13%. So you can see the state's paying about $9,800, and they're paying $1,700 to $3,500. And then if you've got less than that, you're paying greater share of the premium, and this state's paying less. So again, the question is, how much are we willing to shift from the state to the retiree? Just put it there because to me, this is the framework that I think is most helpful to figure out for non-grandfathered retirees in the future. What are we aiming for? What are our goals for shifting dollars from one group to the other? I found that was useful for me to look at it, and if we had some answers there, then we can come back and say, well, then we should put this plan together and that plan together. That's not where we went. That's fine. This is a motion I prepared in September. It was on the agenda, but we didn't take it forward here, but we plan to bring it forward in the November meeting. And if you jump down to the whereas, what we want to do is set up a subcommittee. It won't be under the SCBC to look at controlling healthcare prices. We've got somewhere in the top 10 most expensive states for healthcare in the country. And there are steps that many of us feel that we should be considering and that we're going to need to look at closely. And we need to look at with the same kind of dedication that the subcommittee has used in looking at retiree health benefits. If we are working in an environment where health cares are high, then we can't avoid the fact that our retiree health costs are high. And if we can get our system healthcare costs lower, then we'll be bringing down our retiree health costs. And that will also help the state's ability to fund our future retiree health benefits. So this is an important element that the subcommittee wants to accomplish, and we'll be looking at passing it in some form at the November meeting. So that's the motion. We didn't act on it that day. Wayne Emsley, who's one of our subcommittee members, and he does an awful lot of work on this, has prepared a motion or two. And these are ones, so what this looked at is maybe we should be looking at if you're retiring younger, then the state is paying less of your premium until you get towards 60, 65. So if you retire, let's say you work for 20 years, 30 years from 18 to 48, you retired your 48th birthday, the state, you'd be responsible for 75% of your premium until you get older. And as you get older, then the state pays, you pay less and less of the premium. The state pays more. By the time you hit 65, the state's paying that same 5%. You're paying that same 5%. State is paying 95%. But this says that the state wouldn't be on the hook for 95% of your premium if you retire after 30 years at only 48, with still 17 years between then and 65. This would only be for future retirees who weren't grandfathered. And when brought this table forward to say, we should be looking at making some adjustments in there. That'd be one way to control the costs. Again, do it for only non-grandfathered retirees. And we had some good discussion on this. It did have great support from, we had a number of people on the subcommittee who were present in person, and a number who were there virtually, especially those in person. There was not a great amount of support for this decreasing level of the premium due by the retiree who retires early, even with a lot of years of service. So Wayne prepared a lot of this and looked at the different plans. One of the challenges is that, I'm going to say it's a trade-off between complexity and fairness. To keep it simple, it's not terribly fair, but to make it really fair, you have to make it pretty complicated. And with complication makes it expensive to execute, to explain, to plan, etc. So just recognize that interplay there. This one here, so this is one again from Wayne, also did a lot of number crunching. He said, well, what if we try to make it a little simpler and just say that we're gonna have an 8% increase on the premium for the pre-65, the pre-Medicare retirees, and how much would that save the state in millions of dollars? And look at how many people use the different plans, etc., to come up with about $100 per month savings, shift from the state to the retiree, the pre-65 retiree, the non-grandfathered pre-65 retiree, at $102.56 a month, which is somewhat related to that Medicare premium that is paid by retirees who are 65 plus. So he wanted to present this and said, this is around a $6 million annual savings, which is substantial. So I think it was a good thing to look at there. I want to talk about that a little bit in a few minutes. We have some public comments submitted in advance by Bob Clarkin, and some of it had to do with the report, which again is sort of on hold right now until we finish our work, hopefully next month, our work on the stuff that goes into this report. And with that, I want to go to the document that I prepared here. So take that off. Okay, so first thing I want to point out is that our next meeting is on November 28th from 1 to 4. And we're hoping to finalize our 2023 recommendations at that meeting. And then from 10 a.m. to 1 p.m., we have our December meeting on the 20th, and we hope to finalize the report that we provide to the governor, to the legislature. We hope to have a draft of that report done at least a week ahead of time. So at least by by December 13th, so that the public can review it and provide comments, and the subcommittee members can really look at it in depth and bring any last minute questions forward. But we're hoping to have enough advance time to work on that. Really, I think we want to do less, I'll say, proselytizing and soapboxing, and really just say, here are the motions we've passed, here are the things that we recommend, and that brings us to the next part of this, which is we identified at least 6 different things we want to clarify, and maybe create a single motion that includes them all. And one of the reasons, sometimes with legislation, if you make a bill too complicated with too many pieces, it makes it harder to pass, because then you may have 5% of people who don't like this one piece, 5% don't like that one piece, 5% don't like that one piece, and together you can get up to 50% who don't like at least a piece of it, and you can't get it passed. But in other cases, you have, well, if you did this, then I vote for it, or if you did that, I'll vote for it, and you can sometimes build up by making it more complicated. This, we're hoping it's one, because we've had some complaints, including from the members of the subcommittee who are cabinet secretaries working for the governor, that they feel like we're doing a lot of ruling things out and we aren't pointing out what we are doing. So the idea here is let's include the things that we are doing and make it bigger and make it clear that we want to do this and that, not just this or that. So let's make it bigger and talk about everything that we are recommending in a single motion that we think that will help us get more votes and be able to get it passed, done, and then in the report that we hope to finalize the following month. So the first bullet I have listed here is reduce healthcare costs for all of Delaware. And that's that motion to create a task force, a committee that looks at, let's bring the health costs for our state down somewhere around at least the average rather than the most expensive 10 states in the country. So that is a really important feature. And frankly, we've got some members who aren't all that interested in doing anything else on this list unless we include that one item, understandably. Next thing is talking about subgroups. What do I mean by subgroups? The SCBC, the State Employee Benefit Committee, provides healthcare for 3 different subgroups: all active employees, all retirees who are Medicare age, and therefore the state's providing healthcare on top of Medicare, a Medigap kind of policy, and then all retirees who are not yet of Medicare age. So that's 3 different subgroups. And the way that the SCBC, the state, figures out how that healthcare is provided and the costs and what share goes to each individual and what share is covered by the state is by rating the groups to say, well, this group costs so much per person, and that's the premium, and you pay what X% of that, the state pays the rest, etc. But they don't rate the difference between the cost for an active employee and a sub 65, a pre-Medicare retiree. And as such, we've got a single cost and premium size for there, and we know the data has shown, the data they've provided, created, brought forward, and shared shows that there's quite a difference in cost there, and most importantly, quite a difference between what it costs the state and the premium they use for that. So they undercharge our pre-65 retirees, and they overcharge our Medicare age retirees, and that's not fair. We know it's not fair. Well, we don't want to change it like that, because if we did so, then we would end up doing a big increase to what the monthly cost would be for a pre-65 retiree, and then a relatively non-trivial decrease for the Medicare age folks. And we don't want to do anything dramatically. So we want to glide path into it, have a gradual correction of that. And by gradual, I mean, it could be 5 years, because it could be off by 20%. It could be off by more than 20%. So rating those, the different subgroups, rating the cost of providing the healthcare by the state means that it's something which will correct that. So really, one of the things, remember my chart, my blue and green chart of changes we're willing to make for Medicare age retirees and changes we're willing to make for sub 65 retirees. This is the main thing that we would do for our sub 65 retirees, is charge them what it costs. So instead of having them pay 13.25% of a artificially low cost for the healthcare compared to what it costs to provide that to them, let's still charge them 13.25%. Let's change nothing there other than make sure that the cost of that service that we're assessing equals the cost it costs the state to provide it. And that means we need to rate it. So that rating the subgroups is an important element to more properly charge and collect a portion of those premiums from the pre-65 retirees. So at a fair level to the state, and that's fair to the pre-65 retiree, and it's also more fair for the Medicare age retirees. We want to ensure coordination of benefits for retirees, and this is one where right now, if you have a couple and one of the members of the couple works for the state and the spouse does not, the state will cover the health care for the spouse if the spouse does this process called coordination of benefits, can attest that they are not covered by another healthcare cost. So if the other spouse has a full-time job and has full-time health benefits provided, then they're not eligible to be covered by the state because we coordinate the benefits there. We don't do that in all cases for retirees. So if you are retired and you cover your spouse, but your spouse has a full-time job with full health benefits, then your spouse would not. I think we do properly do coordination of benefits in that case where the spouse has to attest annually that they're not eligible for that kind of health benefit. But what we don't do is we don't have the retiree themselves attest that they're not covered. So if you have a retiree who's worked for 30 years, and let's even say they're unmarried, and then they get a second job once they retire from the state that could provide full health benefits, and they say to the employer, let's say it's a small business, they're like, you know what, I got my benefits for my retirement. You don't have to pay me. You don't have to provide that health benefit. Give me an extra $10,000 in salary because you don't have to pay any health benefits. Well, that's all well and good for the employer, but it's pretty bad for the state because the state is paying health benefits for this individual who is working a job where the employer really is on the hook for that. So we want to make sure that we're doing coordination of benefits for retirees and spouses. And that's a step that should save a little bit of money. It's nothing gigantic, but it's something that's truly more fair to the state. There's some issues. This whole reason we're here is that the state has indicated its willingness to provide health benefits for its retirees. But the state has not provided the money to back up that promise over the future decades. So we've got this funding imbalance. And we care about that. Well, we care about that because we care about our retirees. We also care about that because now bond rating agencies are questioning, well, maybe you've got this, maybe we have a Titanic, we see some icebergs coming here, that a few years from now, we're going to have benefits that we can't pay, that we have to pay, and we're going to start borrowing like crazy. And the bonds that we've extended in the past for highways and schools and things like that, we're having trouble paying the interest on that. So the bond rating agencies are saying, if you don't make clear what you're doing, then we may have to downgrade your bond ratings. And the U.S. government just had that happen in August by one of the agencies because of how dysfunctional Congress has been in recent months. And we don't want to follow DC's footsteps there. So we want to be clear to ourselves and to the public and to the bond rating agencies that we're taking this seriously. We want to adopt a formal funding policy so that we have identified our path. Our path doesn't have to be fix this in 5 years. It could be fix this in 45 years. Okay, but we want it fixed, and we want to make clear what our pathway to fixing it is. And that would be to create a formal funding policy. And we've taken some steps. We've already committed in law that we're doing 1% of the budget annually. And that's $50 million a year going right to the OPEB fund. We've also talked about using this other employment costs OEC. Currently, it's 0.36% of all payroll that goes from the state goes into this OPEB fund. And we have a plan to increase that by about 0.25% a year until the point that together we are at the point, our destination, we fixed it. And that can take 25 years or so. But there's also changes to plans. And one additional piece the Secretary Geisenberg pointed out is let's be formal in our commitment that when we have one-time revenue jumps, and let's say we get whatever it happens to be, but occasionally when we're ready to finalize the budget in June, in May, we saw, okay, this is how much money we're going to have to spend. And then in June, the economic forecasting groups called DFAC comes out and says, you're actually going to have $20 million more than we thought. Well, that's a one-time thing that we weren't planning to use. Let's commit 40% of it. 40% of these one-time June positive surprises right to OPEB fund. Let's have a commitment saying that when we have one-time excess revenue, that a portion of that goes automatically to the OPEB fund. And that also can be part of our formal funding policy for OPEB. So those are 4 elements. And the fifth one is this what are we going to do for future retirees, non-grandfathered ones? We're not changing anything for the grandfathered ones. And our recommendation thus far, based on motions we've adopted in the past, is that we're changing nothing for anyone who is working for the state, has worked for the state, and the only people that this will apply to is those who begin work for the state on or after 2025, January 1st of 2025. So what would we look at changing? Right now we have something called Medicfill, which is like Medigap F. It's also like Medigap G. It's a little bit more generous than that. So what we're picturing is, well, at the least what we would do is we would bring it down to Medigap probably G, because F wouldn't be available to anyone this would apply to, because F is, I'll say, term limited to only apply to those who have already turned 65. But let's say it's G is our default. And then if you want, you may have the option to choose L, which is less generous, costs less, and can save both the state and the retiree some money. Or we have the default is you get L, and if you want to get G, you have to pay up for it. That's a question. It's an A/B question. It's either A or B. So let's get that. We want to get that decided next month in November and get that into the report. So at least those 5 elements we want in this one motion. We prefer to be a one big motion, an omnibus motion, if you will. And we want to get it vetted by some of the, we've got a working group of 3 of us are going to be working on this and trying to make sure that it's written in a way that it has a good chance of passage. So that's what to expect at the November 28th meeting. And that motion likely will be shared more than a week in advance. So it's not a surprise for anyone. And if someone has issues with it, they can share public comment in advance. They can reach out to the subcommittee members with your opinions on it. We want this to be done very much in the public eye. Okay, I have been rambling for almost a half hour now. So with that was the end of my the things I wanted to make sure I talked about. I'm looking to see if there's any questions out there. Actually, I'm going to keep this other thing in the background. Remember, our next meetings are on November 28th and December 20th. At those times, it'll also be posted on the website, the RHBAS materials website. And if there's no questions, I am fine with that, because I've got a Halloween parade and then something else after that, 2 other things after that this afternoon. I probably won't be doing an update until after the November meeting. We're at this point going at a 1 meeting a month pace, but we're doing some work in between. And but I think that pace, one of the things it's a little bit easier to survive and fit into your schedule. So that's where we are going at this point. And if there's no more questions, do know I do post this on YouTube. I download it and get it posted up there for those who don't use Facebook. But thank you for joining in, those of you who are on live. And I will catch you likely shortly after the 28th meeting. And don't hesitate to reach out to me at the email address that is listed there, paul.baumbach@delaware.gov. Thank you very much. Take care.